Hi everyone, good evening and welcome to the Terumo Learning Edge Radial First Go Everywhere with Glidesheath Slender. My name is Jennifer Masabini and I am a Senior Education Manager here at Terumo. I'm joined here with my colleagues Ellie, Ilka, Yara, and Sydney supporting the virtual side of this recording. I have a few housekeeping items that I would like to go over. First, this presentation is intended for US physicians only. Products may not have regulatory approval in all countries, so please contact your local sales representative if you have questions about the availability of products in your area. This will be a recorded roundtable discussion, so if you have any questions regarding the topics discussed or looking for any further Terumo education opportunities, please visit us at www.terumois.com or reach out to your local sales and clinical representatives. We have a great event planned this evening, and leading the discussion will be Terumo's Senior VP, Chief Medical Officer, Dr. Michael Martinelli. Dr. Martinelli is an interventional cardiologist with over 20 years in practice, and I would say probably one of the true pioneers in radial access. So with that, thank you all for joining us tonight. And Dr. Martinelli, the floor is yours. Thank you.
Thanks, Jen, and hi, everybody. And thank you for giving us your time this evening. We have a real esteemed panel to discuss something that's near and dear to our heart here at Terumo, and that's radial access. First, we'll start out by making some introductions. So why don't we go around the horn and introduce ourselves. I'm Mike Martinelli, as Jen said. I'm the Chief Medical Officer for Terumo. My experience is in interventional cardiology. And then we'll go to Dr. Peebles.
Hi, I'm Todd Peebles. I'm a neurointerventional radiologist in Wisconsin. I've been doing neurovascular procedures through the wrist for about 6 years.
Great. And Dr. Resnick is next.
Hi, I'm Dr. Neil Resnick. I'm an academic interventional radiologist in Atlanta, and I've been doing radial access for just over a decade now, 2012.
Great, welcome, thank you. And Dr. Zhiroff.
Good afternoon, I'm Katrine Zhiroff. I'm an interventional cardiologist in Los Angeles. I've been doing coronary procedures through the radial since 2012 and peripheral vascular procedures probably in the last 5 years or so.
Thank you. And last but not least, Dr. Skripochnik.
Hi, Eddie Skripochnik, vascular surgeon in New York, New York Presbyterian, Columbia. I've been doing peripheral interventions from the wrist since about 2016-ish.
Great. Well, thanks. This is a great group to get together and discuss some of these things. We're going to start out, a little general, but probably the most important aspect to radial access, and that's what you all feel are your best practices or your cardinal rules for a safe and successful procedure, diagnostic, or intervention. And we'll get everybody's opinion. We'll go around the horn, and maybe we can start with Katrine, Dr. Zhiroff.
So I think, not to state the most obvious, but the first and most important is actually when you're examining the patient, feeling their pulses, both radial and ulnar, and looking at their hand. Sometimes, especially if they develop spasm, you kind of want to have a frame of reference. So that would be sort of my first best practice. I do not do Allen's test. I honestly don't know if anyone else is doing it. The only time I do that is if a patient says that they have Raynaud's or some type of rheumatological condition where I'm actually worried about some type of small vessel occlusive disease.
Great. And how about Dr. Resnick, from your vantage point?
Yeah, thanks. So from my vantage point, best practices would include, I like to use ultrasound to get into the radial.
Okay.
That way I'm able to do a single wall stick, and at the same time I'm also able to look up the entire arm, or at least most of the arm, to look for any radial loops, to check out the size of the radial artery, and if I see any radial loops, then I may be able to then go ulnar and do transulnar access, so that's helpful. And I do a modified Allen test using ultrasound, actually, and pulse oximeter, just to make sure that there's not that rare Barbeau D out there. I have come across a couple of those in my time. So for me, I still do that. And then to use cocktail and then to use the hydrophilic coated sheath. Those to me are the best practices.
Great. Let's flip it over to vascular surgery. How about Dr. Skripochnik?
So I like to start out with knowing what my plan is going to be for the case, how far I'm going to need to reach. Is it an iliac case? Is it an SFA case? Is it a tibial case? And I like to make sure that I have all the tools available to me when the case starts. So that's planning ahead of time. And then I agree mostly with Dr. Resnick there. I do a Barbeau test on everyone, and I use an ultrasound to look at the vessel, evaluate diameter, quality, calcium in the preoperative area. And then once we're in the operating or angio suite, always access under ultrasound guidance and radial cocktail for everybody. Great.
I flipped it over to you, Ed, because I am not a routine ultrasound of the radial artery, but of the groin. And I've spoken to some people and I've gotten various answers about this. And I had one gentleman say that he would ultrasound before the case. And if he felt that the vessel was too small, which I was finding out in many of his cases, he felt the vessel was too small, he would not do a radial procedure. So that kind of, fueled my interest in does everyone really do ultrasound for every case? And do you feel that it will limit your procedure from radial access? Maybe I'll slip over to Dr. Peebles and then you could jump back in on that.
Yeah, with regard to ultrasound, initially I started out doing everything kind of proximal radial, and I was more concerned with how much time, learning radial might add to my procedure duration. So I was skipping the ultrasound initially and just going with manual puncture, which worked probably 90% of the time. I think it's really essential though to use, and I think there's a lot of value now, I understand too, and looking up the radial artery and anticipating any radial loops or anything. So there is definitely an advantage to that. But also, if you're going to go more distal too, like in snuff box, then it's really essential to use ultrasound. So now I pretty much use ultrasound in every case, and we just get it ready, and it's ready right from the outset, and that makes it easy.
Yeah, I think you're right. I think snuff box it's definitely an exception. That's almost a mandatory ultrasound. We're referencing traditional, but we'll get there. What are your thoughts on that from a cardiology standpoint, Dr. Zhiroff? Do you ultrasound, especially, and I'm thinking a STEMI?
Yeah. So I actually started using ultrasound later because it is best practices. I think we know from data your chance of a single stick access is better. But especially with fellows and, I still do half and half. I still try to get at least half of my cases without ultrasound guidance, because in a STEMI situation, even though it's 2-3 minutes, it still adds time. So I want to be able to reliably, use my anatomical landmarks. I think you mentioned something interesting to me, because I always feel like the worst case outcome could be that you look at the radial, it looks small, and you switch to the groin. So most of the time, if you didn't look, you probably would have gotten access to the radial, given a cocktail, and the case would have gone just fine. So I think, it is important though to get more experience with ultrasound, just to see the different anatomical variants, and especially for patients who have calcification, I find it helpful to sort of get a nice access site where I don't have to worry about not being able to compress the artery for hemostasis later.
Great. Anything else to add? Anybody? Dr. Skripochnik? Vascular surgery.
I think I'm here to push back on ultrasound guidance.
I think you are.
I think 100% of the time, it doesn't matter what kind of case should have ultrasound guidance. And I've just fixed too many damaged vessels from the groin to the wrist to the brachial, I mean, pick a location. Myself and my colleagues have fixed them all. So, and once you become very savvy with the ultrasound, it should add maybe seconds. And I know other people are using fluoroscopic guidance, and I think that's slower than ultrasound. So I would say that there is no slowdown, and I wish that nobody would know how to do a blind stick anymore.
Good, great. We got it all over, all across the board today. That's
I'll
great.
add something too,
Sure.
if we have a moment. I think ultrasound and even a modified Barbeau using ultrasound adds confidence to the case, in my opinion. So I understand that there's this idea that maybe you're going to find they're too small and you're going to wave off and say, let's go groin or something. My experience has been that if you ultrasound, if you do Barbeau, it's not D. And now you are using ultrasound, a single wall stick, despite the size, no matter what the size, you have a lot more confidence that that you're not going to cause damage and spasm, especially using the rest of the best practices we talked about. So even things like GI bleeds, where the vessels could get a little bit smaller potentially, I'm routinely still using radial access. I rarely use groin. I mean, I've maybe ultrasounded 1 or 2 wrists in my whole time of doing this, there where I said, let's go groin. The rest I've done from the radial. So I think it adds confidence rather than kind of takes you away from cases. I think as you do more and more cases and you have more confidence with the skills, you'll be willing to go smaller and smaller with your sticks.
Sure, that's great. They're great, great insights, everybody. Oh, one last thing about best practice, anticoagulation. How much do we do?
For me, for neuro stuff, I'll give, if it's just a diagnostic, I'll usually give 50 units heparin per kilo. For interventions, I'll go with 80 per kilo. And I think that's important.
Everybody normally going from 50 to 70 units per kilogram for a case?
Yeah, you guys are smarter than I am. I just go with a kind of set dose. I just do 3,000 units of heparin and 2.5 of rapamycin, 200 mics of nitro, and just do that routinely.
Right. Everybody using a cocktail or just nitro or just calcium blockers?
I use a cocktail and I start with 5,000, but then once I've determined that I'm going to be doing a intervention, then I'll go up almost to 100.
Okay, great.
I'll also add one more thing, just because
Sure.
maybe we're often asked to do interventions in the setting of bleeding patients, and so the question comes up frequently: do we still give the cocktail? And the answer really is it depends. It depends on how the patient's doing hemodynamically. But often I've over time given less and less of it, and if it's truly emergency, patients hosing out blood, I often will not give the cocktail at this point.
Great insights, thank you. Well, thanks so much everyone for all your time and your expertise. We really appreciate it. I think that these types of discussions are really beneficial for our audience, and we're certainly grateful to have real champions like yourselves. So thank you very much, and we really appreciate all the time you spent.